One of the things that we've talked a little bit about working with employers. Now I want to talk about how we work with specialists, and we talk about getting these transparent prices. And I just kind of want to address a little bit in my talk about how do you start? Where do you get to these transparent prices, and what's possible? So I just want to kind of go back to the beginning with us. Our company name, of course, is Epiphany Health, and if you've heard my talks, you've probably seen some of the stuff. And our epiphany was, why are we insuring primary care? Why are we using the least effective, least efficient model of healthcare payment insurance company to finance the most basic aspects of medical care? So if I'm going to give you $1, the most efficient way is to hand you $1. It's not to hand it to you and every single person in this room that touches that dollar take a penny out of it so that you can file a 30% processing claim to receive that $1. That makes no sense. But that's what we're asking for primary care to do. And so when we look at it, what are the things that are actually driving up the costs of the care? It's not primary care. Primary care is definitely not the cost driver. But what happens outside of primary care is extremely effective at driving up the cost of care. So the hospital stays, the administrative costs, the medications, surgical care, these things all start to raise it. So you guys all know what direct primary care is, but what we've done is sort of put that model on steroids, and we built a very robust network of people around our practice that are able to help us, giving us transparent prices on services, because we know what we do is cheap. A 3-cent ear speculum, that's no big deal. That's not going to break you. But if I send you to get an MRI, that's a big deal, and we need to know what that costs, because I think what a lot of you will find is that a lot of people that are seeking you out will either have no insurance or will be carrying a high deductible plan that really needs to find some value, and you need to be able to understand what the costs of services are around your practice to be able to guide them. Josh mentioned previously, first do no harm, and that includes doing no financial harm. When you send a patient for a test or a battery of tests, you should have a pretty darn good idea of what it's going to cost. And so we have the unique ability to do that in a direct primary care practice that the insurance-based practices just can't do. And that makes us very powerful, very effective, especially for somebody like a self-funded employer that really wants to see those costs contained. So you've heard this a lot today already, the free market, because we're the free market folks, and the free market brings down costs and improves access and quality, because a LCD television screen that comes to the market, it's expensive. Now you start to make it better, more efficient, faster. You can make it just, before you know it's a Black Friday special and it's dirt cheap. But people look and they say, well, we tried the free market in healthcare and this is what it gave us. We did not try the free market in healthcare. So then they say, well, wait a second, look at the EpiPen. You remember the EpiPen? EpiPen, this is 10 cents worth of medications, and all of a sudden the free market, the capitalism, made a $100 pen a $600 pen, and now we're blocking access to life-saving care because of capitalism and the free market. But when you listen to when these people were called down to testify before Congress, and they asked them, how could you do this? And they said, well, patients weren't supposed to pay that price. These high deductibles now the patient's paying the price. And so in the shame that came from that, they immediately lowered the price of their EpiPens to $300 the next day. So the reality of it is that the obscuring of the actual cost of the EpiPen allowed it to get to $600, and when you unveiled the actual cost to the consumer, there was outrage over a $600 EpiPen that brought the price down in half overnight. That's what the market did in healthcare, when you actually let the market work. So we can bring some of that pressure to bear on the healthcare system. And when these people are talking about bending the healthcare, we have the ability to break the healthcare cost curve, just destroy it. And we're going to show what some of those costs are down here. So, you've heard this said many times before. We don't use insurance to replace light bulbs and mow your lawn for basic maintenance. We're not going to use it for primary care. Because if we're trying to sell an insurance policy, and we're gonna create this thing, and we're gonna put it in a box, and we have to sell that box for one single price and call that box health insurance. In that box, we're gonna put our nice, affordable primary care services, but then we're gonna put in a bypass surgery, an end-of-life stay. We're gonna put in chemotherapy, the rheumatologist biological agents. We're gonna pack all that stuff in there. We're gonna sell that at a price and call it insurance. It artificially raises the cost of access to primary care, but when we strip all that other stuff out, the cost of access to primary care comes crashing down, and this is what we're all about here. Now the question is, can we as direct primary care doctors affect all that other stuff that we've now taken off of there? And that's where I think you guys have the ability to start getting crazy. So I always like to show this. This is the insurance-based practice. This is something that's very simple, making it very complex. This is a Rube Goldberg toothbrushing machine. So this is the insurance-based practice, but direct primary care strips away all that stuff and just makes things very simple and more cost-effective. This is nothing new for you, but so in our practice, we include 25 visits per year in our membership fee. We have some things that we pass along costs to the patient. Anything that gets sent out, we pass that cost along to the patient. And I'm going to get into some further details here, but we charge $60 a month for an adult, $25 for one child, and $10 for each additional child. These are price points that you guys will have to determine what works for you. Some people age-base these things. A little difficult to see, but when we charge a fee for service for some of these things, it's $200 or $300 worth of services that we're including to add value to our practice. People say, well, do you charge for this? Do you charge for that? No, we don't. It's all included there. So I'm going to show you what we're able to accomplish, but how do you even start building this support network? The first thing you have to do is ask. And it can just be a simple ask. Go to one of your specialists. I'm going to send you patients. They're going to be cash paying patients. Just give me your price for the top 10, 15 things that you do in your office. Go to your specialists. That's where it has to begin. I just had somebody that came in that owned a fitness center. And I said, are we able to establish corporate rates for our patients? So we'll establish as a corporation, and our patients that come see you, they get the corporate rate discount for your program. So there's ways where you can get creative to add more value for your patients. I put down there seeking independence. It is so difficult to work with hospitals, and with all the consolidation that's happened across the country, if you're in a market that is just dominated by a large hospital with no independent practices, no independent imaging services, you're going to have some challenges. So try to find those mom and pop pharmacies, try to find those mom and pop radiology and imaging centers, because that's where you're going to get the most penetration. You can reach out to the labs and try to set up client billing accounts. That's kind of the magic word, is client bill. So Quest Diagnostics does it, LabCorp does it. And what a client bill basically does is you're the client. I'm establishing an account with you, and the patient pays me for the labs. I get the bill from the lab. So basically, I'm using the patient's money to pay the lab, but that allows us to buy it wholesale. So the conversation with the lab initially, now I think it's built into some of the EMR systems in here, but our initial approach to LabCorp or to Quest is we'd say, we're going to send you 500 self-paying patients. Would you like to bill 500 patients, try to collect from 500 patients? Would you like to bill 500 patients' insurance plans and wait for them to process, see what the deductible is, and then try to collect the money from those patients? Or would you like me to collect the money up front and you send me one bill for 500 patients? Their biggest cost, if you look at what Quest is charging, their most expensive thing is labor. It's not the lab test. So if you could eliminate all their labor in that, the prices of these services come crashing down, and in many cases you see 95% discounts on lab services. For our imaging centers, we oftentimes would take the Priceline.com approach and say, do you own your CAT scanner? Okay, is it running 24 hours a day? If it's not, if I sent you a patient that was willing to come in and pay you cash at the time of service, what can you sell me your unused CAT scans for? What could you sell me your unused MRIs for? Because it's just sitting there vacant otherwise, so they might as well get some money off that. And so, again, we saw huge savings, and you'll start to see what some of those are. For our specialists, I think one of the keys for us to make this sustainable and scalable is that we call it sort of the no cringe test. This cannot be seen as charity for the practices that you're trying to refer patients to. If they think that this is charity, they're going to cringe when you start sending them more and more patients. So what we usually tell our specialists is, give us a price that you're happy when our patients call you. You want our patients to call you. So set a price that's fair and put it on paper, but start somewhere. So we've done this now for years. We now have actually a hospital that has given us bundled cash pricing on all their inpatient and outpatient surgical line. That's probably among the first in the country for for uninsured patients to actually have cash bundled prices. We now have 2 national labs that we're working with. We have 3 physical therapy groups, 4 imaging centers. We have 3 pharmacies. Now, a lot of people here are going to be dispensing in-house. Some states you cannot dispense. We do not dispense, more out of choice than out of the lack of ability to do it here in Florida. But initially, we reached out to the independent pharmacies and just said, when our patients show up, can you give them discounts? And they gave them discounts. And so we had arrangements with the independent pharmacies for it. But it turns out that the Good RX program out there was actually as good, if not better, than some of the arrangements we were getting. So the Good RX, you can see discrepancies of $100 on a single prescription just with that alone. So even if you're not going to dispense, you're still going to want to find ways to find value for your patients and explore these services. We have 2 optometrists. Our patients now get discounts on eyewear, eyeglasses. We have, again, we're working on a fitness center. We have a dentist now that's giving our patients preferred pricing. And we've approached specialists over the years. We have now cardiology, GI, general surgery, orthopedics, urology, ophthalmology, and podiatry that has given us all the prices on their services. So when our patient goes and has a procedure, they know precisely what they're going to pay. They know if they're going to the cardiologist what the office visit's going to be. They know what their echo is going to be. They know what their stress test is going to be. That's all given to our patients up front. And in many cases, what we found is that our patients that have insurance, and many of them do have insurance, they pay more if they pull out their insurance card than if they left their insurance card in their pocket. So I think Phil's probably going to talk about the HITECH Act that allows patients to tell the practice that you can't disclose that I'm getting this test to my insurance company, don't bill them for this, and that is a provision that's allowable. Because what you'll get is the pushback from the specialist saying, wait a second, the patient has Blue Cross and I have to bill Blue Cross for it. That's actually not necessarily true, but you have to do it in a certain way that Phil's going to describe, but it can be done. So just kind of some of the prices that we've seen for our nuclear stress tests are about $500. Our CT scans are $200. Our MRIs are $225. I've heard a couple lower prices than that, but not many. I'm going to talk about this colonoscopy in a bit. Chest X-ray is about $20. So some of these states now are mandating price transparency, and you might think that that would sound like a good thing. But what they're mandating is actually charge transparency, which is monopoly money. And I read an article, I think it was from North Carolina, or North Carolina, Virginia, one of those states passed one of those laws, and they were bragging about how this price transparency saved the system so much money. And the example they used was one facility charged $4,000 for the MRI, and the other facility charged $3,000 for their MRI. Therefore, price transparency saved the system $1,000 per MRI. Well, my MRI is $225. You could fly from North Carolina to Florida, stay at the Ritz-Carlton, have a 5-star dinner on the Gulf of Mexico, fly home, and still save about $2,500. So it's the charge transparency is not as important as the actual price transparency, which again is some of the unique things that we're all doing in this room here. I put down there that our colonoscopy is $850. Actually, our colonoscopy now is $1,000. The interesting thing about the colonoscopy is that the pathology component of it. So if you go in and you have a simple normal colonoscopy, great, $850. Oh, sorry, we did 2 biopsies. And you wake up for anesthesia, and now all of a sudden you have a $2,000 pathology bill that you weren't planning on. So we actually have worked with our provider. The colonoscopy is actually now bundled at $1,000. So the price going in is the price coming out. The pathology is now bundled into our colonoscopy. So there's no bait and switch. It's the same price no matter what. So what can we do now that we've put this together? What is the power of this? So this is, Chad was showing his hospital bills. I like to show my hospital bill. And so this is a real patient that went to the emergency room for abdominal pain. This is a copy of their bill. And for full disclosure, I sit on the board of this hospital, and they hate that I show this everywhere in the country. And I said, well, fix the problem, and I'll take it down. I'm still showing it. So the hospital for that ER visit charged almost $20,000. Now, I can get patients in my office immediately, oftentimes quicker than the emergency room could see them. I can order stat labs, I can order stat imaging services, and again, many times I can work these patients up faster than they could have had they gone to the emergency room. So using my prices, I could get that $19,000 or $20,000 hospital bill down to $301. That's the difference. I mean, so the monopoly money's on the left and the real dollars are on the right. And so what's going to happen now is you're going to have the insurance companies, and I don't want to beat up on the insurance companies because we do like insurance. We need insurance. It's an important thing. We're just using it wrong. But they're going to come in and they're going to say that $20,000 hospital bill, and they're going to say, thank goodness you had XYZ insurance because we're going to go ahead and discount that monopoly money to $5,000. And oh, by the way, your deductible is $6,000, so stroke the hospital a check for $5,000. You've not saved $15,000. You've just paid $5,000 for $300 worth of medical care, and you paid $1,000 a month to the insurance company for the privilege of doing that. So this is a story I like to take. We actually had our first case of inbound medical tourism from out of the country. We had a patient that lives in the Caribbean island of Antigua, and up in the upper left-hand corner, that's Dr. Elena George. She's an ear, nose, and throat surgeon in Atlanta, Georgia, and she does mission work down in Antigua, and she diagnosed a patient down there with thyroid cancer. And the patient checked to have a thyroidectomy in San Juan, and they quoted her $100,000 to have her thyroid removed in San Juan. Elena contacted Keith Smith, and Keith said, yeah, we can do the surgery, but the problem is with the thyroid surgery is we're going to need preoperative assessment, we're going to need imaging services, we're going to need a stager, we're going to need an endocrinology consult, we're going to need blood work, and we're probably going to need about 6 months of postoperative medical management to make sure to get her on the thyroid medication to get everything regulated. We can't do that. So Keith contacted me and said, Florida's a lot closer to the Caribbean than Oklahoma City, so would you co-manage her with us? And so she got a 6-month medical visa, came to the United States, she came to us, we did all the staging, sent everything coordinated with Oklahoma City. She went out there, had her surgery, came back, we managed her for another 6 months, and she went home. The total cost of everything, including her travel, was about $10,000. So now, we have an arrangement with our hospital, our rural hospital area that's reached out to us and again given us bundled cash pricing. So we now have a price for a total knee replacement. So if you look in the United States, a self-insured or uninsured patient is probably going to be billed about $125,000 for a knee replacement. They're probably going to be paying about $45,000 to $60,000, and you referenced the $75,000 just the facility fee, $75,000 facility fee. Now, you have the medical tourism abilities, so in that upper right-hand corner, you can go to Singapore and you can get that same surgery for $18,000 to $22,000. Our price right here in Florida is $18,550. Now, that sounds expensive. That's a lot of money. But for a self-funded plan, that's a big savings. And so if you're a self-funded plan and you're looking at sending a patient to Mayo Clinic or some facility that's going to charge $125, and you've got a facility down the road that's going to charge $20, there are probably plenty of ways you could structure that plan to incentivize the patient to go to the $20,000 facility, as long as the quality is where it needs to be. So there are creative ways where we can just, again, bust the system wide open. There's so many cost savings. And so now the Millman Index is now showing that a family of 4 with a PPO plan, the total cost just for their coverage, that includes the employer's contribution and the employee's contribution, is now $26,000 per year for those PPO plans. The employee's contribution, or the employee's portion out of pocket now, is about $11,000. That's a lot of money, and we have the ability to really hack into that $11,000 and bring that price coming crashing down. So we've heard all about the skyrocketing cost of healthcare. I can tell you that since our practice launched in 2010, we've lowered our prices. Okay. So I think that's one of the interesting things is that people will say, well, the cost of healthcare is just going through the roof. Actually, if you look at the cost, and you probably look at this, Jay, over the years, the actual cost of the procedures is not going up a whole lot. The cost of the coverage plans are going up tremendously, but the actual care is not skyrocketing in most cases. So this is the difference between the cost of coverage versus the cost of the care that most people are getting. So a family of 4 in our practice will pay $1,800 per year for essentially unlimited management of their chronic conditions for primary care services. But that PPO coverage is about $25,000 a year. So the difference between the coverage and the care now is almost $24,000 per year, and many of these people are now carrying a $7,000 deductible. So one of the pushbacks that we get is saying, well, if you get a patient that's going to have a high deductible health plan, what happens? I mean, these people don't have $10,000 sitting in their bank accounts to be able to afford these catastrophic conditions when they come up. So if you look at that black line across the bottom there that says $37,320, that is what a family of 4 would pay over 10 years for a direct primary care membership plus one of these short-term medical plans. So a catastrophic $10,000 deductible, and this one happens to be through Golden Rule. I just looked that one up. So $37,000 per year is what they're going to pay. If they had a traditional PPO plan, we showed that Millman index, they'd pay $258,000 for that. So the net savings between those two is $220,000 over 10 years. So again, that's savings that between an employer and the employee, that's $220,000 that's left to be spent in other places. So let's just say that's the sickest family in the world, and they hit that $10,000 deductible every year for 10 years. That's $100,000. You still saved that system $120,000. Lots of money to be saved out there. So, if you look at the Affordable Care Act, assuming it was working perfect, let's say we wanted to fully support it, prop it up, fully fund it. If carried out is exactly as it was designed, the expectation is that you'd have 32 million people that would be insured, and the assumption is that 26 million people would have remained uninsured. That was the assumption going in. And the 10-year projection for that is about $1.8 trillion to leave half of the uninsured still uninsured, and the people that were uninsured were largely under the expansion of Medicaid. So if instead of doing that, we took all 58 million people, and by the way, that's just giving them coverage. You're still having those $7,000 deductibles and still having access to care issues. But if instead you gave them all the access to care, we just signed them all up for our DPC membership, the net 10-year savings over that is about $1.4 trillion. This is a very powerful group. You guys have the ability to change the world. Use your powers wisely. Thank you.